Good morning. I'm Mark McClellan. I'm the director of the Engelberg Center for Healthcare Reform at the Brookings Institution, and on behalf of the center and especially the staff of our High Value Healthcare Project, I'd like to welcome all of you and thank you for taking time out of what I know are very busy schedules. We've got a lot of people here who are doing a tremendous amount of work on quality of care, and particularly quality of care related to populations that are disadvantaged. That's always a busy and difficult job. On top of that, as many of you have noticed, this has been an unusual week in terms of healthcare reform, and with all of the activities related to that effort that are ongoing, which many of you have been directly and extensively involved in. We're delighted to have such a great turnout as we discuss what I think is one of the core issues of getting to a better healthcare system and how we can develop data-driven strategies to address it, and that is going after disparities in healthcare and in health. As we're gathering here today, that healthcare legislation has been enacted. The modifications to the bill are being debated in the Senate. Change is coming. Major changes are coming. But changes in insurance coverage alone, I know we've had a lot of talk lately about health insurance reform and the importance of making our health insurance system work better. You all know that changes in health insurance coverage alone are not going to eliminate the disparities in healthcare and health that exist today. In addition, though, the healthcare legislation presents some tremendous opportunities to improve the way that our healthcare system works. These will be challenging to implement, and a lot of people have pointed out ways in which these efforts can go wrong. But that puts a lot of burden on all of us here today to make sure that we do as much as possible with the unprecedented reform opportunities ahead of us. How healthcare reform legislation is implemented is going to be critical to core issues like healthcare disparities. And we need to be accountable for healthcare reform really helping all Americans get the best care, not just better coverage. Some provisions in the law provided a stronger foundation for addressing disparities in care. Along with establishing broad national priorities for quality improvement, the new legislation directs the Institute of Medicine to focus further on activities that would help reduce health disparities, such as by making recommendations on the development and implementation of policies and practices by healthcare organizations for providers of limited English proficient patient populations. But the impact, the potential impact on quality of care goes far beyond that. As the President likes to say, there are a lot of good ideas in this bill in terms of changing the way that healthcare providers are paid, in terms of developing better information and evidence on quality of care and on effectiveness of treatments, all of which could lead to significant improvements in care for disadvantaged populations. That's a could, that's not a will. It depends on what we actually do to implement this law, and I can't think of a better group to get together at a more critical time to discuss those issues than all of you who are here today. A tremendous amount of work now is underway around the country to improve the quality of its care, and many of you in this room have focused on not only those quality improvement issues, but making sure that those quality improvement activities extend to all Americans, that help us get to real reductions in disparities. And so today, we think it's the right time to shine the spotlight on the specific quality issues that are faced by many vulnerable groups in our country, in particular on racial, ethnic, and linguistic minorities. And not only to shine that spotlight, but to provide a path forward, that we truly have some unprecedented opportunities to act upon as a result of new legislation. So through this conference, we have several key aims. First, we are going to show ways in which it is feasible to get much better evidence, indirectly and directly, on disparities in healthcare and their consequences for the routine delivery of care. And second, that this evidence can make a real difference in addressing gaps in quality that disproportionately affect minority, low-income, and different language groups. If you can measure it, you can do more to address the problem. Our measures are not perfect, but they're better than a lot of people think. They're better than they have been in the past. There's a very promising path for the future, and importantly, based on what you all are doing, it's not just about measurement, but it's about taking feasible steps to act on those measures to improve care. None of this is automatic. None of this is going to be automatically executed as part of the new legislation, and that's why this conference today is so important. That's why what you all are doing is so important for the success of healthcare reform for all Americans, particularly the most vulnerable. So we've got a great opportunity here, and the more that we're each able to contribute together, the more we can truly address the challenge. Now, before we begin, I want to do a couple of things. I've got some special support that I want to acknowledge, and I want to go through some logistical issues. In terms of support, I truly want to recognize and thank the Robert Wood Johnson Foundation for their generous support, not only of this event, but of a range of interconnected, high-value healthcare project activities at the Brookings Institution and in many of our collaborating organizations. We've got people here from RAND, we've got people here from universities and research groups who have worked closely with us on this projects, and I particularly also want to thank the staff at Brookings who have worked so hard on this project, developing the activities that we're going to talk about today. By viewing these issues as interconnected and by viewing them as a core, an integral part of any effective strategies for measuring quality and improving quality, we think we found a very effective way forward to make sure that health disparities and healthcare disparities are addressed as a core part of what I think of as real healthcare reform, and that's not just changing the insurance rules, it's changing the way that healthcare is delivered in this country for the better. Thank you. Thanks. I appreciate the applause this early in the morning. That's really something. Also, as a follow-up to the work that we're doing today, we're not done. We're going to be producing a working group paper. That's going to be based on some of the background papers that you've seen that some of our advisors for this project help us put together. We'll focus on strategies for improving data collection and measurement, for advancing health IT, and for using these measures related to disparities to promote reduction in disparities in healthcare and improvements in health. So this is going to be a follow-on to the preliminary work that we've done already. It's going to incorporate the results of the discussion today. So while we are going to be paying close attention to what you all say, to what you all do, we will probably be coming to you with follow-up questions to make sure that we're capturing all of the best opportunities to move this work forward beyond the conference today. The paper, which is going to be developed in consultation with our advisory board and with that further input from all of you, is going to be available within the next 6 to 8 weeks, and we intend to use it and other results from this conference and the ideas that we bring forward together as a key part of our further work on implementing better measures of performance and on working to make sure that we do not miss what I think are the most important opportunities within this overall healthcare reform effort. So now on to the events for the day. We've got a very full agenda with some additional presentations and a plenary session before we move on to the breakout sessions. At noon, after that first breakout, we'll reconvene here to begin lunch and what I think will be a very interesting and timely presentation by our Surgeon General, Regina Benjamin, who cares deeply about the issues that we're discussing today. Just a couple of other housekeeping things. Remember to turn off any loud ringers on the cell phones and the Blackberries while you're in the sessions. The sessions held here in the ballroom are being recorded on video. We do expect to use these to support our subsequent work. There are members of the media who will be in attendance during the day, so please keep in mind that your remarks are going to be considered on the record. Also, most of the sessions will allow for questions and answers following the presentations, and our staff will have handheld microphones available for you to use during the Q&A portion. So if possible, it would be great for you to wait until you get an actual microphone so that we can make sure that we get the question recorded as well as the response. And of course, please try to keep the questions brief and identify yourself by name and organization when you're asking a question. Finally, we definitely want your feedback on the conference itself. When you checked in this morning, you got an evaluation form. We would really appreciate it if you take a moment to fill it out. either at the end of the sessions that are described on that form or at the end of the day. If you have to leave before the conference ends, you can go ahead and drop it off then at the registration, or you can just give it to us on your way out. We really want your feedback as we make these efforts as effective as possible going forward. So that's what I have in terms of preliminary background, and I'm very pleased to now get started. So I'm looking forward to hearing from this morning's opening speaker, Dr. Olivia Carter-Pokras. She is an associate professor at the Department of Epidemiology and Biostatistics at the University of Maryland School of Public Health. For more than 25 years, Dr. Carter-Pokras has conducted health disparities research in the federal government and in academia, and she has an extensive history of ensuring that the community has a voice in research conducted at the national and local levels, a great way to make sure that it's relevant and to make sure that people are going to actually act on it. Prior to joining the faculty in Maryland, she was director of the Division of Policy and Data in the HHS Office of Minority Health. She has been recognized by many for her career achievements towards improving racial and ethnic data and developing national health policy. She's also an elected member of the American College of Epidemiology's Board of Directors and the American Public Health Association's Executive Board. Dr. Carter-Pokras, we are pleased to have you here today to provide some opening comments and to introduce our morning keynote speaker, Dr. John Lumpkin from the Robert Wood Johnson Foundation. So, Dr. Carter-Pokras.
Good morning. It's hard with the lights to see everybody, but I know we have many friends and colleagues who are in the room, many of us who have been in the trenches to improve racial ethnic data, so it's so exciting to see us all convened again today. The Institute of Medicine has defined health equity, healthcare quality as having the following properties or domains: effectiveness, efficiency, equity, patient-centeredness, safety, and timeliness. Although equity has been listed as a separate domain, it relates to each of those other 5 domains. Does everyone have equal access to quality health care? Is the care that is provided supported by scientific evidence? Does everyone have efficient care? Does everyone have access to care that meets their needs and preferences and provides education and support? Is this care safe, and does it minimize delay? Years ago, during routine review of patient satisfaction surveys, the Veterans Administration noted that Latinos were more likely to be delayed in being seen after they arrived to their appointments. Upon further investigation, the Center for Minority Veterans learned that instead of using medical interpreters or bilingual staff, Spanish-speaking Latinos were made to wait until the end of the scheduled day to be seen, since they were perceived by the staff to take longer. That's why they were made to wait till the end of the day. And so this regular review of available data resulted in improved care, since the patient-centeredness and timeliness problem was identified, which could then be addressed. In this room today, we have many individuals who have been at the forefront of ensuring that legislation and policies are in place to establish and support systems that can be used to monitor whether we are providing health care of equal quality to those who may differ in personal characteristics other than clinical conditions or preferences for care. Equity. Recommendations and reports over the years have guided these efforts, including those from the U.S. Department of Health and Human Services Data Council, the Task Force on Black and Minority Health, the National Committee on Vital and Health Statistics, and the Institute of Medicine. More locally, the Maryland Department of Health and Mental Hygiene's Office of Minority Health and Health Disparities, hey, Dr. Hussein's here, and Montgomery County Government's Latino Health Initiative all have contributed to development of recommendations to improving data. From the speakers today, you will hear of efforts to address continuing data problems at all stages: data collection, analysis, and dissemination. Problems such as underrepresentation in sample surveys, lack of subpopulation data, lack of distinction between foreign-born, native-born, and country of origin, and incomplete, missing, misclassified, and inaccurate data. Our data collectors are also grappling with increasing cell phone usage, declining response rates, and increasing costs of data collection. I'm seeing a lot of nods in the room. In Maryland, our cancer registry has always collected Hispanic ethnicity. However, the variable was not always entered into the abstract completed by reporting facilities, or the data were not in the medical chart. There is a field to capture country of origin, but facilities do not routinely record the information. Most of this data are either missing or blank. Indeed, from a recent report from the Joint Commission, this is not an uncommon problem. Only half of the 60 hospitals studied collect ethnicity data. Few hospitals stratify their quality measures by race, ethnicity, and primary language. Some common recommendations to address these problems include increased funding for data, increased sample size, combine several years of data. To do that, we need to ask the same questions. Ask new questions of interest, such as birthplace, language, and health literacy. Translate and provide bilingual interviewers. Expand our data collection methods, especially to address cell phones. Incorporate in-person interviews. Standardize our data collection. Provide training to data collectors, and improve quality control. The recently passed Patient Protection and Affordable Care Act includes language to improve the collection and reporting of data on disparities in healthcare. For instance, calling for collection and reporting of race, ethnicity, sex, primary language, and disability data for participants of federally conducted or supported healthcare or public health programs, activities, or surveys. Use of the Office of Management and Budget standards for racial ethnic data. Development of data standards on sex, primary language, and disability status. Additional safeguards to prevent inappropriate internal use of disparities data, standardizing state data collection for Medicaid and state children's health insurance program, and a report on how to improve identification of healthcare disparities for Medicare beneficiaries. One aspect of addressing equity and healthcare quality that is not mentioned in this act, or for that matter, much elsewhere, is how to avoid stereotypes that may be fueled by observed differences. Understandably, we've been devoting considerable effort to improving our collection of these data. However, less attention is being paid as to how we use the data and how we talk about any differences that we find. I see some nods in the room. In a review of 3 leading epidemiologic journals, we found that fewer than half of published U.S. studies provided a rationale for including these data. Of studies that mentioned race ethnicity, 3/4 included racial ethnic data in the analysis, yet the results of these analyses were discussed in only half of studies, leaving it up to the reader to interpret what the findings mean. Despite the definition offered by the Office of Management and Budget that race is a social cultural construct, the federal government defined race as a social cultural construct in 1997. Supportive findings from the National Human Genome Research Project, medical dictionaries and texts, and comments from physicians, other healthcare professionals, and those who are still in training often support a more biological, genetic view of race. Costs associated with health disparities in the United States have been estimated to be $309 billion annually, equivalent to the gross domestic product of India, the 12th largest economy in the world. One approach to address disparities in health status, healthcare access, and healthcare service delivery in the U.S. that's suggested by the Unequal Treatment Report for the Institute of Medicine is to integrate cross-cultural education into the training of current and future health professionals to improve the quality of healthcare and healthcare communication. Cultural competence is now recognized by various governmental and accreditation agencies as essential for eliminating disparities related to patients' health status and access to care. For example, the Joint Commission has proposed requirements to advance effective communication, cultural competence, and patient-centered care for the hospital accreditation program. Healthcare system interventions to increase cultural competence can include programs to recruit and retain staff members who reflect the cultural diversity of the community, use of interpreter services or bilingual providers, cultural competency training for healthcare providers, use of linguistically and culturally appropriate health education materials, and culturally specific healthcare settings. Health may be improved through these approaches because clients gain trust and confidence in accessing healthcare, and healthcare providers increase their ability to understand and treat a culturally diverse clientele. In our earlier article on language access services, we noted that the risk of medical malpractice occurring due to language discordance between providers and patients is almost certainly reduced when competent medical interpretation is provided, and should be taken into consideration when weighing the costs and benefits of interpreter services, as the cost of malpractice can be quite high when an adverse event occurs. Health literacy is an important aspect of cultural competent healthcare. how a patient understands and uses health information is directly tied to his or her cultural attitudes and beliefs. The patient's health literacy can be affected not only by cultural beliefs, but also by low educational level and limited English proficiency. The culturally competent healthcare professional must not only respect the patient's culture and beliefs, but also his or her ability to understand the health information being provided. Health professionals incorporate health literacy principles into their practices, programs, and policies as a means of reducing health disparities and increasing positive health outcomes. The Patient Protection and Affordable Care Act increases access to care, but it does not ensure that individuals and families will be able to access, understand, and use information regarding how they get insurance and get care. This act will require even greater health literacy on the part of individuals and families seeking to get covered, and providers who will be seeing more people. Insurance companies and providers have an opportunity to use plain language in forms, documents, and other ways of communicating. Families and individuals of diverse backgrounds and capabilities will be challenged to get the information they need, understand that information, and act to best help themselves and their family members. This act will require not only health literacy, but financial literacy. There's room for involving communicating educators to help increase these literacies. The impact of culturally competent training of health professionals on patient outcomes, even though mentioned several times in the Act, has not been adequately evaluated. Recently, an article published in the Annals of Internal Medicine by Sequis et al. Compared diabetes patient outcomes among Blacks whose physicians received training to those who had not, and concluded that although cultural competency training combined with individual clinician-level performance feedback on racial disparities increased awareness of disparities. However, such changes were not accompanied by improvements in diabetes outcomes for Black patients. Now, why is that the case? Well, it's interesting that the Act that has just been passed supports the development, evaluation, and dissemination of research, demonstration projects, and model curricula for cultural competence, and inclusion of cultural competency and health literacy training in primary care training programs, dentistry, and dental hygiene. However, it is important to note that there is great variation in what is currently included in cultural competency education and training. Much of what is offered reinforces stereotypes. If your patient is Latino, then this is what you should do. These are the beliefs that all Latinos share. And I can tell you, that is not the case. So what do we do instead? I'm a member of 18 educators across the country that have been funded by the National Heart, Lung, and Blood Institute to develop cultural competency health disparities curriculum. This national consortium for multicultural education for health has spent the last few years discussing what should be included in this type of training. We have decided what's important to include is to emphasize a social cultural definition of race, incorporate discussions of differences within the context of human rights, structural inequalities, and social injustice, and emphasize self-assessment and building skills such as motivational interviewing and how to work with medical interpreters. The National Consortium for Multicultural Education for Health Professionals' overarching vision is to embrace and enact the principles of high quality, equitable, and culturally responsive care, and to eliminate health and healthcare disparities. I'm eager to hear our speakers today talk about how their efforts help us achieve that vision. And for those of you interested in learning more about our efforts, I did bring a binder with examples that I'm quite willing to share with you. So thank you, and I have the great opportunity to introduce a colleague who was one of those individuals in the trenches since he chaired the National Committee on Vital Health Statistics when I worked in the federal government. Dr. John Lumpkin is a senior vice president and director of the healthcare group at the Robert Wood Johnson Foundation. Before joining the foundation in April 2003, Dr. Lumpkin served as the first African-American director of the Illinois Department of Public Health for 12 years. He's a member of the Institute of Medicine, of the National Academies, and a fellow of the American College of Emergency Physicians and the American College of Medical Informatics. As I mentioned before, he chaired the National Committee on Vital Health Statistics. I think it's the oldest advisory committee in the Department of Health and Human Services. If not the oldest, it's one of the oldest that's continuing to run. He's also, a chuckle as we know what's happened before with advisory committees. He also has chaired the advisory committee to the director of the U.S. Centers for Disease Control and Prevention, which houses our main statistical agency within the federal government for health statistics. And he also chaired the National Institute of Medicine's Committee on Assuring the Health of the Public in the 21st Century. He served on the boards of directors for the Public Health Foundation and the National Quality Forum. He has been author of numerous journal articles and book chapters and received numerous awards. He earned his MD and BMS degrees from Northwestern University Medical School, his Master of Public Health degree from the University of Illinois School of Public Health. He was the first African American trained in emergency medicine in the country after completing his residency at the University of Chicago. So I will not delay you any further. I'd like to introduce Dr. Lumpkin.
Good morning. And I want to thank all of you for coming here to discuss what are very key issues for our nation. As you know, this is part of a larger, multifaceted project, the High Value Healthcare Project, and it's a project that we at the Foundation are proud to support because we believe it fills an important void in the effort to create high-value healthcare in this country and to make sure that it is widely accessible, consistent, with consistent information about the quality of health care available for use by anyone who gets care, who pays for care, or who delivers care. I want to thank Mark McClellan and his team at Brookings. Thanks to their work, this project is moving on many fronts to use the power of measurement to highlight racial and ethnic disparities and point the way towards viable improvement and solutions. I'm pleased to be here today among so many people working on an issue of paramount importance to every American, using data to measure and reduce racial and ethnic disparities in healthcare, which is critical to achieving a high-value, effective, efficient, affordable, and equitable healthcare system. This issue is vital to our healthcare system, to our nation, and it's important to me personally. In 1966, Dr. Martin Luther King Jr. said, "Of all the forms of inequity, injustice in healthcare is the most shocking and the most inhumane." I grew up in the civil rights movement and graduated medical school just 8 years after Dr. King made that speech. One of the people who had a big influence on my life was my Aunt Pat. Aunt Pat helped convince the mother of Emmett Till to go public about her son's lynching. And it was that open display of his casket and his mutilated body which ignited the civil rights movement in Chicago and created a national outrage. Aunt Pat was bigger than life and quite intimidating to adults, not to mention an impressionable child like me. Now, my father had 9 brothers and sisters, and I had a ton of cousins. Now, whenever a family member went to the hospital, Aunt Pat asked me, or should I say, told me, to call their doctor and find out what was going on. And being a dutiful nephew and fearful of not doing what Aunt Pat said, I made the calls. And of course, this was before HIPAA, so people actually talked to me. And now, after each call, I reported back to Aunt Pat in excruciating detail, and she was almost dismissive of the results of the call. It was as if making the call was all she really wanted. And it took a while before I realized the fact that as a doctor and being a member of their family, and the fact that their provider knew that, made Aunt Pat feel much better that my uncle or cousin would get the care they needed. My aunt, like many African Americans believed then, and many minorities believe now, that because of the color of their skin, they would not get good health care. And the data bears out that belief. African Americans die at a younger age than their white counterparts. They're less likely to get interventional cardiac treatment. They're less likely to have their diabetes managed. They are more likely to get amputations due to peripheral vascular disease. And while the ARC disparities reports have noted some improvement, disparities in healthcare delivery still exist today. And that's why we are here. African Americans and other racial and ethnic minorities believe that they don't get the same care because of who they are and how they look. Others feel they don't get the same care because their providers don't speak the same language they do. And the data seems to support these beliefs. Studies have shown that patient satisfaction is highest when there is a racial and ethnic concordance between a patient and their provider. Patient satisfaction is higher when the provider speaks the same language as the patient or a trained interpreter is used. And providers have more satisfaction when that is the case. Yet, our understanding needs to go a little bit further. Studies have also shown that providers make decisions based upon the race and socioeconomic status of their patients. Yet, standing here today, I have to say that I do not believe that physicians and other caregivers intentionally choose to treat their patients differently. Now, a few years back, I was writing an article, and I did a lot of review of the literature on how and why humans use numbers. It seems like, okay, now what does this have to do with this? But humans use numbers as symbols to represent things in the real world. The human brain cannot really appreciate objects greater than 5 or 6. Now, all of us know, we're talking about billions of dollars in a budget. But what do I mean by that? If you were to put objects in a bowl, paper clips or whatever, or marbles, and you just look at it and didn't count, and then someone asks you how many were in there, you can go up to about 4 or 5 before you have to start counting what's in the bowl. In other words, you're associating these marbles with a symbol, with a mental image. And we've survived as a species because of the ability to associate objects and put them into groups and associate things and put a symbol to them. That plant is safe to eat, and this one isn't. These animals are okay to be around, and these animals are pretty dangerous. This group of individuals, they're part of me, and these folks aren't. But when we take our mental symbolic representation of what a group is and apply it to individuals in that group, then we're stereotyping. And in the context of our society, that's a bad thing. But when we use stereotypes to make clinical decisions, that leads to bad outcomes and bad treatment. In most people, this is an unconscious process. And it takes a conscious effort to move beyond it. In essence, healthcare providers need a blame-free environment where they can learn about their unconscious tendencies and consciously treat the patient in front of them. This is how they gain cultural competency. Yet, cultural competency training, as Olivia said, can only go so far. As the Crossing the Quality Chasm noted, just trying harder as an individual is not enough. To get different outcomes, we need to do things differently. Disparities occur not just because of how racial and ethnic populations look, talk, or act. Place becomes an important factor. In 1990, I was appointed director of the Illinois Department of Public Health by Governor Thompson. Inequities in health was one of my central issues. I noted that there were many similarities in the health statistics for Cook County up in north where Chicago is, and Gallatin County in the far southern tip of Illinois. Anybody here ever been to Gallatin County? Well, I get the same response if I ask that question in Chicago. I've been there. Both had similar and high rates of infant mortality. Both had high rates of excess deaths due to heart disease, the deaths that occurred when you calculated what you would expect if you use statewide averages to the population in that county. Both had high rates of death due to violence, but Gallatin County had no African Americans. They had statistically almost no minorities. It became clear to me that African Americans in Illinois, well, I forgot one other thing about Gallatin. Gallatin had the same poverty statistics as Cook County. And what became clear to me was that African Americans in Illinois had poor health, not just because they were black, but because they were poor and black. Yet again, this is just part of the story. As we learned with the publication of the report from the Institute of Medicine on unequal treatment, that even when you adjust for social economic status, inequities in race and ethnicity still persist in healthcare. I want to share with you three disparate pieces of information that help me understand where we need to look if we're going to find a way to reduce racial and ethnic disparities in healthcare. First, I attended a presentation by David Nairns, who's going to be heading up the next panel. And he put up a slide comparing the rate of adherence to guidelines and management of asthmatic children in Michigan after an acute episode that resulted in an ER visit or hospitalization. And the rate for African American children was half that for the white children. Now, Michael Rothman, who some of you may have known, one of my colleagues at the foundation at the time, leaned over to me and he said, you know, the problem is the rates both stink because the rates for the white children was only 50%. To make a real difference, the goal cannot be just to reduce the gap. What we have to do is improve the quality for everyone. This need for more than just disparity reduction was highlighted by another piece of information. Communities with a high percentage of African Americans have more excess mortality than other communities. And this is not startling in of itself. But what these communities do, they have a higher rate of excess deaths for African Americans, but they also have a higher rate of excess deaths for whites and others who live in those same communities. Something about place is important. And the last piece came when we looked at a study by Ash Sagel. And I think many of you may be familiar with this. He looked at a long-term project to improve adherence to guidelines for the use of renal dialysis. And using quality improvement methods and tools and rates of adherence, he nearly doubled the adherence to the guidelines from the high 40s to the mid-80s. Then when he went back and looked at the changes for African Americans, he had also seen some in that same period more than doubling from the mid-30s to the mid-80s. Quality improvement can have a major impact of all populations. Pondering these facts, we tried to understand why some communities had poorer outcomes than others. Poverty may be one reason, but communities of color tend to have lower average income and higher rates of poverty. Of course, my Aunt Pat already knew that. But why? Was it just that the providers there wanted to deliver poorer quality care? Well, I've worked on some of the inner city communities in the city of Chicago, and I knew that for the vast majority of the providers, that was not true. But what was true then, and is true now, is many of these hospitals operate on the brink of financial ruin. They could not afford the resources to hire the experts to help them adopt quality improvement methods. And that's where Bruce Siegel, who's sitting back over there, and the Foundation's Expecting Success program came in. 10 hospitals serving large Hispanic or African American populations were competitively selected and received technical assistance and worked in a national collaborative focused on improving quality of care of patients with cardiovascular disease. Each site started off with data collection. Now, as you know, and will be discussed at this conference, data collection can be a bit complicated. And I'd like to share with you one lesson we learned early on, and that is how you communicate about collecting data on race and ethnicity makes a big difference. In 2003, we were doing a polling asking people how they responded to about legislation to allow insurers and health providers and employers to ask people for information on race and ethnicity. This was while there was something going on in California, some proposition. We got about 400 interviews into the sample, and a trend was becoming very clear. Minorities who were asked that question, 60% of them were opposed to the collection of this data. So we went back and we redesigned the question. Because that response actually couldn't have been that surprising. Because I could just remember my Aunt Pat telling me how doctors and hospitals tended to experiment on black folk. So when we changed the question to say, the information would be used to ensure all Americans receive the same level of high-quality care, the 60-40 margin flipped in favor of collection of race and ethnicity data. With that in mind, Expecting Success hospitals went to work. In Detroit's Sinai Grace Hospital, for instance, there were too few white patients to even measure disparities within the hospital. At this resource-starved yet willful community hospital, what Expecting Success did was give Sinai Grace tools it could not afford, it couldn't afford on its own to reduce door-to-balloon times for heart attack patients. The program started in 2005, and by 2007, it was meeting the standard of care for more than 92% of the time. But Expecting Success did more for Sinai Grace than improve quality. It became a fulcrum for broader change. As the CEO, Conrad Mallett Jr., said, it caused the hospital to think of itself differently, and it caused the community to think of us differently. In hospitals with more mixed populations, collecting data became a powerful tool for opening eyes to equity issues that the people who ran the hospitals didn't even think existed. At the University of Mississippi Medical Center, for instance, they discovered that they were seeing more than 3 times as many Hispanic patients as they thought. They used this information to hire 3 full-time Spanish-speaking interpreters. Another hospital discovered, much to its surprise, that a statistically significant disparity existed between black and white patients in one aspect of treatment for myocardial infarctions. When the hospital drilled down into the data, it found a 3-physician group treating predominantly African American patients with performance that was subpar. A chart review revealed that the group was not consistently following the hospital's clinical guidelines. The data became a discussion point. They started that discussion between the hospital and the physician group, and with some hard work, these disparities disappeared. What we learned from this work is that we do not have a national quality or disparities problem. What we have is a quality and disparities problem in every single community of this nation. And it is a local problem. And if we want to eliminate disparities as part of our quest for high quality, high value, equitable care, we must change the facts on the ground in each community. To learn how to do that, we're taking everything that we've learned about quality improvement and disparities reduction from 2 decades of work at the Foundation in both acute and outpatient settings, from programs like Expecting Success, a nursing-centered program transforming care at the bedside, Speaking Together, which has used quality improvement methods to aid adoption of appropriate language services, and putting that all to work in a program we call Aligning Forces for Quality. This initiative is a real laboratory operating in 17 communities across America, using measurement and public reporting to drive and guide the adoption of quality improvement. No 2 of these communities are alike. They range from tiny Humboldt County in California, where Eureka is, to entire states like Minnesota, Maine, and Wisconsin. From communities that never tried these kinds of strategies to some of the country's most experienced regions at measuring and reporting care. Together, they represent over 34 million people in over 650 hospitals. The goals of Aligning Forces for Quality are to help clinicians improve the quality of care for their patients, to engage people to become better partners with their doctors, and make informed choices about their care, to improve care across patient settings, outpatient, inpatient, in those areas where there's focus on nurses as agents of change, and to reduce racial and ethnic disparities in care for patients through measurement and reduction of gaps. To meet this last goal, our alliances throughout the country are training health plans, ambulatory and inpatient providers, and their staff to collect, standardize, self-reporting data on race, ethnicity, and language. They're collecting the data, they're using the data to stratify performance measures, and they're using the results to target quality improvement efforts. We're learning a lot and already are seeing some promising results when we surveyed key providers in our communities. What we found was sound evidence for the need to advance consistency in race and ethnicity language data. For instance, we found that the data is being collected in some form by many providers and to a somewhat less extent insurers, but generally not in a standardized manner. Early adopters in the Aligning Forces community tend to share two characteristics. First, they have strong organizational and executive commitment to quality. Second, they have a business need. They see equity as integral to quality improvement and necessary to respond to their patients' needs and remain competitive in their markets. These rationales seem to be common among the providers who serve large or growing minority populations. For instance, our alliance in West Michigan is working with two of the largest hospital chains to reduce health disparities. These systems have been able to collect race and ethnicity language data for 100% of patients with heart disease. Our Cincinnati Alliance reports that 15 hospitals have agreed to the data collection training, which is a major commitment of resources, time, and staff in an economic downturn. Our experience with our Cleveland Alliance shows the impact of electronic health records. Of the 42 practices submitting data, 31 have an electronic health record. The high penetration and use of electronic health records enables the Alliance to better capture patients' information, regardless of insurance status or other barriers to conventional measurement, and to offer sophisticated support for their providers and their patients. So we know, for instance, that African American and Hispanic patients in Cleveland with diabetes have poorer outcomes of quality measures for blood sugar, blood pressure, smoking, cholesterol, and weight, and we can target interventions accordingly. This gives us a glimpse of the possibilities that health information technology holds for reducing disparities. It is important as we monitor adoption to make sure that adoption does not exacerbate the gap between the have and the have-not practices and the patients they serve, and instead becomes a powerful tool that Cleveland teaches us it can be in the fight against disparities. The idea that we'll reduce disparities in communities is a powerful reminder of the importance of making sure that the solutions we discuss today at this meeting will work on the ground in places like Cleveland and Humboldt County. As you can tell from my description of the equity work in Aligning Forces, the panels and breakouts today touch on key vital issues: standardizing data, the business case for collecting race, ethnicity, and language data, making meaningful use of health information technology to advance equity and quality. This is incredibly important work. It is a critical part of our efforts to make high-quality health care affordable for everyone, and it's critical that we get it right. Now, my Aunt Pat is no longer with us, but her challenge to be caring and fair lives on in the work that we're going to be doing today. We know what's at stake. We know that our goal is not just to turn the numbers around, but to turn lives around. The road ahead may be long and frustrating, but with every event like this one, every contribution from our researchers, and with every lesson we learn on the ground and in the communities, we move a step closer. We must take each opportunity to make progress. In the words of Oliver Cromwell, we need to strike while the iron is hot, but we need to keep striking to keep it hot. I want to thank you for the efforts that have brought you here, and to encourage you to work hard today and after you leave as we move towards our common goal: high quality, high value, effective, efficient, and equitable health care for everyone in this country. Thank you.
Good morning to everyone, and we certainly appreciate your being here to share your time with us as we address topics related to data collection and disparities in quality and ways of dealing with those disparities. My name is Dave Nairns. I'm from Henry Ford Health System in Detroit. I've been working on healthcare disparity issues for quite a number of years, and had the privilege last year to chair an Institute of Medicine committee dealing with this question of standardization of race and ethnicity data collection, and that report was issued in August of last year. My job this morning is not to talk specifically about that report, but actually to draw out some of the thoughts and observations of members of this expert panel who've also been thinking from a variety of perspectives about the issue of collection of race ethnicity data. And our particular charge this morning is to think about this question of a standardized approach to collection of race ethnicity data. The way this will work this morning is we'll take about a half hour for some discussion and interaction among the panel members. And although I don't know if we have things that we will argue directly about, that we might, we'll see. And we'll do that for a while. We have a few questions that we'd like to address and bring out. But then there will be opportunity for questions and dialogue with everyone in the audience. And as you heard earlier, there are some microphones available when we get to that point, and we certainly encourage you to use them. The members of the panel this morning include Ramana Hasnain-Winia, who is director of the Center for Healthcare Equity and a professor at Northwestern University. Barry Straub, who is director of the Office of Clinical Standards and Quality and the chief medical director at CMS. Marcia Regenstein, who is a professor at George Washington University, co-director of the Center for Healthcare Quality. And Linda Bilheimer, who is with director of the Office of Analysis and Epidemiology at the National Center for Health Statistics. The extended bios are in your meeting materials, and people have said they'd rather take their time to discuss things, so I will leave the introductions at that. I will, though, just by way of an extended introduction, ask each of our panelists to just take a couple minutes and talk about their background on this issue of collection of data on race, ethnicity, and language, and sort of what perspective they bring to this issue, and then we'll go from there. Ramana?
Great. Good morning. Is this on? Well, it's really a pleasure for me to be here, and I feel like I've been on somewhat of a journey when it comes to the collection of race, ethnicity, and language data, specifically within healthcare organizations. So that would include hospitals and health systems and physician practices, as well as health plans and community health centers. It's interesting because I've been doing health policy and health research for about 20 years, and I would say I've spent the last 10, almost the last 10, talking about the collection and the use of race, ethnicity, and primary language data. And it's interesting because some of the people in the room are longtime colleagues, and we started this work together, starting with about 5 hospitals and health systems to address disparities in healthcare. And we got these leading hospitals and health systems together in a room to develop a multinational targeted intervention to reduce disparities. We talked about what clinical areas we would target, how we would do it, and then we all silently looked at each other because we realized that no one had good quality data on race and ethnicity and language of the populations that they served. So we took a big step back and started to really look at how to systematically collect data. And we've been doing this now for quite some time. We're going to hear a lot today, and we already have from the speakers, about the importance of standardizing the collection of these data. I had the privilege of serving on the IOM committee that Dave just mentioned, and why it's important to standardize and collect these data in a common way and then actually use the data to improve quality. Dr. Lumpkin made the point that we can't just target the disparity, that we have to improve overall quality of care. And I'd say that the flip side is also true. We can't just improve overall quality of care. We have to target the disparity because we want to see an improvement in overall quality, but we also want to see a reduction in the gaps that currently exist. So I'll stop there and move on to my colleagues.
Okay, Barry?
Yes, good morning to all of you. I thought I'd start off with saying probably what everybody in the room thinks about from time to time, especially since Henry Louis Gates and his recent book and the public broadcasting series that he's led, that we all come from a variety of backgrounds, and oftentimes, unbeknownst to us, we come from those backgrounds. I happen to be half Portuguese, and it may come up in the discussion that ensues, because I've always been very confused about is Portugal, which is on the Iberian Peninsula where Spain is, part of Hispanic background or not. And there's quite a bit of debate about this. So I think there's some struggle with how do you define ethnicity, and don't we all have ethnicities that may have some relevance, particularly to healthcare delivery and the inequities that we are measuring. I work at CMS. You all know that CMS runs the Medicare, Medicaid, and CHIP programs. We have 114 million beneficiaries in those 3 programs alone. We spend over $800 billion a year. And we serve or have serving our beneficiaries about 1 million physicians, over 6,000 hospitals, over 6,000 dialysis facilities, over 40,000 skilled nursing facilities. And the observed disparities in healthcare occur in all of those facilities and in the 17 different provider types that we have contracted to in the Medicare program. So this is an enormous leverage point, which we have, in my opinion, a very great responsibility as an agency to move the dial and to affect the disparate measures that we will be talking about this morning and through the day. We have 6 strategies, and I think it's important to appreciate how much leverage but I think each and every one of our organizations have. Maybe not every organization has the 6 I'm going to describe, but we have to use those. And in order to use these strategies, we need the data that we're talking about today. We need more accurate data. The strategies are what I call contemporary quality improvement. It's measuring things, having evidence-based interventions, implementing those, remeasuring, assessing how good a job we've done. And there's many ways we at CMS, but all of us are involved in contemporary quality improvement. Second strategy has to do with transparency, public reporting, and availability of data. And that's the guts of what we're talking about today. We do that through our Compare websites and many other public reporting vehicles. The third strategy is in our incentives, particularly financial incentives. And now we're in the midst of embarking on even greater payment reform through our programs. And that's a huge strategy. In and of itself, it can't do it alone. The fourth strategy has to do with our regulatory ability to use conditions of participation, conditions for coverage of all healthcare facilities. And we can set certain standards that people have to meet, including race and ethnicity and other disparities requirements that they have to meet in order to be paid by Medicare, and ultimately, since private payers often mimic us, by private payers. The fifth strategy has to do with our national coverage decision process and what we choose to cover. And that may seem strange to you, but in fact, we have conditions we can put linked to the coverage policies that could in fact impact who provides it, how it's provided, and it can address race and ethnicity and other disparities in some circumstances. And then the sixth strategy is to do appropriate research demonstrations and grant programs to facilitate improvement in or reduction of health disparities. So those are our strategies. I will later want to talk about a report to Congress that we have in the process that is very germane to this area. I did want to end, though, it kind of is a take off with what John had been talking about. And I'd urge us, as we've done at CMS, to remember that health disparities are not just race, ethnicity, and language disparities. We have chosen to put that as our top priority of the many, but I think we do have to, as John was alluding to, think about the other kinds of disparities, including gender and age and geographic location, socioeconomic factors. We have to think about condition disparities. That is, some people with certain conditions are not treated the same way as people with other conditions. And then another one that doesn't get talked about a lot, but gay, lesbian, bisexual, and transsexual populations that have disparities also. So, David, thanks.
Good. Marcia?
Thanks. Good morning. As Dave mentioned, I'm at George Washington University, and I've had the privilege and the joy of working on several of the quality improvement projects that the Robert Wood Johnson Foundation has invested in. And I've worked on the Expecting Success program that John mentioned and have seen some of the advances that can be made with quality improvement in terms of raising the bar for everyone and improving quality. And I ran a program called Speaking Together, which was about language services and improving access to and quality of language services. And now I work on aligning forces for quality that sort of brings it all together and really looks at quality from a community perspective. And prior to that, I worked with a lot of public hospitals and large health systems that had very diverse populations. I've been interested in this for many, many years, and Ramana's the guru here. I think her work really did, many of us have worked in this area, but the work that HRET did was really a catalyst. It was groundbreaking, and I think it has served as a sort of a guidepost for all of us. There are a lot of complexities in this area, but having worked on these quality improvement programs, I think that there's sort of an elegant simplicity that can arise when you look at some data and you can see that people are not getting the care they need, or that you can see over time how care has changed. And I would challenge this group to try to get to that elegant simplicity. That we can spend all of our time talking about the complexities of data collection, but we have Ramana's work. We have Dave's leadership and the IOM report. We have the QUASC work. We have what we need to move forward. And that doesn't mean we are where we need to be. We're not. But we're no farther behind than any other field. Disparities is an epidemic. And we need to be vigilant and start talking about how we cure and treat the epidemic. I look across this room, and what I'd like to see is, not today, perhaps, because there are issues of data and they're real, but what I'd like to see is a disparities meeting where we don't talk at all about the data. We talk about what needs to be done. We talk about policies that need to be implemented. We talk about the quality field and how disparities fit in there. We talk about costs and bending the curve, and we talk about disparities and the investment that needs to take place. And we leave those data details to being resolved, like any other field of data details are resolved, by using the data. John mentioned the Conrad Mallett situation. Mr. Mallett is the CEO of Sinai Grace, and a more dynamic or inspirational leader I have never seen. And he did have a crumbling hospital, and Expecting Success turned everything around. And he went through a process where all of the registration clerks were trained in the uniform collection of race, ethnicity, and language. They collected all the CMS measures around heart care. But it wasn't the data collection that changed everything. It was his passion for quality and his belief in his people that could turn the hospital around. And there was a meeting of all of the CEOs of Expecting Success where he saw in his data that he was outperforming some of the other hospitals in this collaborative. And if I'm not mistaken, he emailed 2,000 employees, "We're better than the rest. We can do this." And it was the investment of the leadership that made the difference. So what I'd like to see, and I've worked a long time in language services, I called the CEOs of that program and said, you know you're paying a lot for language services. Do you realize that only 30 or 40% of your patients are getting an interpreter when they're being discharged? Things change when the CEO feels that the quality of the care that that institution is providing is subpar. And you can show evidence that that's happening. So I think the data is key, but my point is I think we have enough to move forward. It's really hard to take the level of simplicity and then talk about what really needs to be done as an agenda for change. But if there was ever a time to be optimistic about an agenda for change, I mean, it's now. So that's what I encourage everybody to do.
Okay. Linda?
Well, as the representative of the statistical agency coming after Marcia, what can I say? As the representative of the statistical agency, we have a somewhat different focus. And I think part of our challenge is to resolve what may be a data tension, if you like, between the perspectives of organizations that are looking within the four walls and our perspective, which is looking at communities, states, and the nation, and populations as a whole, and the population as a whole. I agree with John that this is not a national problem, but we do need national statistics that enable us to look at the problem more broadly, and I would say not just the problem of quality of care within institutions, but also problems of healthcare access, which are critical and for which we need data that we cannot collect from medical records. So resolving some of these tensions about how we can produce national and state level data, how we can have denominators for data and calculate rates, while there is a very strong drive to have much more granular ethnicity data, as we saw in the IOM report, and which we certainly understand and appreciate, is some of the challenges that we face and that I hope that we can talk about today. Also, I think one of the things that we are now facing, and this has been the last couple of years has been very transformative, I think, with regard to people's views about population health data, and a very strong drive to come down to, again, to one of John's points, to produce community data, that decisions and policies are going to be made at the community level, and this relates both to organizations and institutions and also to public health organizations as well. And we have had a lot thrown at us saying, so what are you going to do to help us to have better community data? How are you going to move beyond just producing national statistics? And we are really in the middle of this right now. And again, it is something that we can talk about because we have a lot of initiatives going on that are both within NCHS and also more broadly within HHS to promote more accessible and better use of community level data. But some of the things that we are thinking about also is how we can develop maybe a national standard that produces state-level data, and then have surveys and data collection at the sub-state level that can be benchmarked to consistent state-level estimates that we produce. So all of this is currently ongoing and an ongoing discussion, and I would very much enjoy having questions and more further conversation throughout the day.
Let's see if we can just play off that comment a little bit then on the general issue of standardization before we get into some of the details. That from the NCHS perspective and perhaps from CMS, standardization seems like a natural thing because you have fundamentally a national perspective. And so a set of categories or a standard set of asking people ways to get that information seems like a fairly natural thing. But in the organization that I'm in, it's one organization in one place. Romana has typically worked with single organizations. Marcia, you work often with communities or single organizations. When you adopt that perspective, you can say that what would work best in Detroit is not necessarily what would work best in Denver or Seattle or Honolulu. So how do we blend or balance these concepts? How can we create standardization on the one hand for the larger levels in which we would want to do that analysis, but allow that local flexibility? Are these things inevitably in conflict, or can we make this work?
I don't think they are in conflict. And I think actually this was one of the issues that the IOM report addressed, which is if we are seeking information on granular ethnicity, very detailed ethnicity data, clearly different communities, different populations are going to be important. And in some communities, some populations will not exist at all. And we know that different ethnicities tend to cluster in different communities across the country. So having a list of ethnicities from which organizations can choose what is relevant for their organization and their community, but having it standardized so that we can aggregate up to some larger aggregate measures, I think is the way to go. I think it's complicated. I think it's very complicated. But I think that is the type of discussion that we need to have.
You want me to jump in, David? First of all, I think we all are in agreement and have given the same speech that you gave about wanting to act on the data we have. That's very, very important. Since the panel, though, is charged with data collection to start off, and I think the day was nicely planned.
Data collection meeting? I'm sorry. I'm sorry.
I was going to pass you a note, but
Mark and the staff have nicely, if you look at the agenda for the day, we get to that. But I do think that the data is very, very important. And David, to get to your question, because it does get down to the local level as well as being at a national level. Because we have a national program, we've been struggling with how do we not just measure national issues, but get down to a local level, to individual provider level, individual beneficiary level, quality measurement, for instance. And of course, by extrapolation, looking at race, ethnicity, language, and so forth. I thought it'd be interesting for the group to know how primitive things are actually at CMS. We are charged under Section 185 of the Medicare Improvements for Patients and Provider Act of 2008 to deliver a report to Congress, which is going through clearance right now and will come out in April. And this is supposed to look at ways of improving Medicare data as it pertains to race and ethnicity. This was in the IOM report from 2002. There have been several other national recommendations made for CMS to do this, and I think we're finally getting at that. We get our data. We don't collect race and ethnicity data directly at CMS. We rely on enrollment in the Social Security program. So the Social Security Administration, for the most part, collects data. And from the get-go, at the beginning of Social Security, there was one field that could be populated, and you have 4 choices to populate that field: white, black, other, unknown. And that has, up until 1980, that was collected maybe at the time that we all, those of us who are old enough, signed up for Social Security, which was usually when we first got a job and went to work. Starting in the 80s, Social Security cards were issued at the time of birth. So that's an improvement in that now everybody is getting a Social Security card at birth, but it's hindered by the same data field restriction. It was mentioned earlier that, again, OMB came out in 1997 with a better classification of race and ethnicity. But that has not been fully adopted, nor is it fully populated in terms of the Social Security data, which then comes to Medicare that we use for our own data analysis. So we've had to go over the years, and when Mark was administrator, he worked hard with the rest of us in leading this to try to improve the quality of the data. We look to other sources. We look to the Census Bureau. We look to a variety of CMS surveys. We look to a variety of other data collection points to scrub this data that goes into eventually our enrollment database. There's a daily refresh, if you will, from Social Security Administration with their new process. But basically, I think, David, that to what will likely come out in our recommendations is that we probably need to relook at the Social Security and census collection of this data. If we solve both of those problems, which we think are solvable in the near term, it just takes political will to do so. We could then at least have a fairly accurate national database that gets down and can be tapped at the local level to provide this kind of information. There are other interim methods that you can use, using surnames, and we do use that to a certain extent to try to refresh our data. One can look at geocoding, that is looking at predominance of various race and ethnicity in various locations. So I think it's a combination of those, and I just alert folks to be on the lookout for that report. I think we're going to be able to make some great progress, not only at a national level, but providing it at a local level.
Good. Okay. We will like to try to get back to those indirect methods in a little bit, but Marcia?
You mentioned the community level. So it's true that community to community is very different in terms of what information matters, both to the individuals in the community, the providers in the community. And then within a community, there are differences that matter. So certain healthcare organizations in a community may see one population and others see none of that population or that language. And so what we believe is that there is a way to have uniform data collection that is respectful of the individual's preferences, the provider's realities of who their patients are, and that you can collect the information in as granular a way as makes sense, that then can be aggregated up to categories that roughly work for most of the population. And you know, there's a lot of debate about some of the smaller categories, but for the most part, there's a structure, I think, that is in place, and we're trying to train individuals in aligning forces communities to be able to use these conventions so that they can capture the information that they want, that can best serve their patients, but also capture it in a way that can be aggregated up and be used uniformly across communities.
So this conversation about national standards that make sense for CMS or for the CDC or for any organization that wants to collect national level data. So this tension between standardized data that can be reported out versus standard data that can be used within organizations to improve quality has always been, and Dave mentioned that I've done a lot of work with individual organizations. So the tension has always been, you know, should we be collecting these broad categories? And I'll refer to the broad categories as the OMB categories for now. And many organizations have been collecting broad categories, and not always in a standardized way, despite the OMB recommendation. So there's been a lack of consistency there. But having those data, that's good, and it's good for reporting, but it's not enough. And I think that's something that, you know, we definitely recognized, and a number of individuals are here from the IOM panel. Paul Scheibe is here. I know John Ianian's here. We talked about, you know, what do we do in terms of our recommendations? Do we recommend that healthcare organizations collect the standard OMB categories, but we recognize that that's not enough for doing targeted quality improvement, for targeting the disparity and reducing the gap. So the recommendation was to collect OMB categories, the standard broad categories, in addition to the granular ethnicity that could be used to do quality improvement work, to target educational interventions at the local level. And I don't think that that tension is so paramount at this point. I do think that we have a good enough list where we can get granular ethnicity and aggregate that or roll that back up to broad categories for reporting out. But I do think that there is this, still this tension within organizations that they can do either or and not necessarily do both. And I completely agree with what Marcia said in your opening remarks, that we really have to move beyond these discussions about how do we collect the data, what are the problems with collecting the data, and start to collect it and to actually use it. But I do think that we have to acknowledge that we have two purposes for collecting the data. One is for reporting and doing national comparisons, and one is for doing local or organizational quality improvement. And those two are not in opposition. They can be done together. And it's very possible to do them together.
Okay, Barry?
Just one thing to add to Romana's remarks, though. I think there's more than just the two. I think there's the six that I mentioned, because when you are going to reimburse a provider based on adjustment for race and ethnicity, there probably is a higher bar that we have to meet in terms of the accuracy of the data than just what I again call contemporary quality improvement. So we can do all of the above. We have to move on with some of those efforts, but we have to be careful on the use of the data, and there will be different standards or bars set, I think, in terms of the quality of that data.
Right. If we could just explore the issue of the more granular ethnicities a little bit. It was one of the newer recommendations of the IOM report, and you stated part of the rationale that in order to do locally based quality improvement, often you need to know people's background at that level. We also, in the committee, reviewed data reporting significant disparities at the level of the granular ethnicities, say, within the broad OMB category. So I think that is reasonably well understood. Because people are not currently doing this much now, though, we have some challenges in front of us. I'm wondering, let me just pose a couple of these specific questions and see what you think. We have people coming back, and I think this is just a paraphrase of what you said. We have IT people coming back and saying, well, wait a minute, I have one field in the database. It currently is essentially the OMB categories. Now, what am I going to do with this other? Do you want me to put the granular categories in there, or what? Okay, so there's an IT question. There also have been questions raised about exactly how one provides these response options, since there are something like, 300 to 400 possible granular ethnicity labels. Do you hand someone a sheet of paper with all of them presented and say, check the ones that apply? Do you select the ones that matter locally? So I think as we enter this new territory, we're going to have practical challenges. And I suspect at NCHS, some of these have been addressed already because you've at least had to think about in the various data collection functions that exist, how deep into the granular territory you wish to go. So I guess that this question is to anyone. How are we going to move forward in this, since this is relatively new territory for most organizations?
Well, I think that, I'm going to echo Marcia again. I think that we need to move forward. I think that we have, laid out some recommendations, not just through the IOM, but through other organizations. We've talked about the Joint Commission work. So the recommendations are there. And I don't think there is going to be a one-size-fits-all for everybody and for every healthcare organization, because we know that organizations are at different points in terms of their evolution, even around adoption of health information technology. So there will be organizations that are handing out a paper form and asking individuals to fill it out. And in that context, it may not make sense to ask OMB race, OMB ethnicity, English proficiency, and then have a long list of 80 or 90 or 100 granular ethnicities. And I'm saying this as a very real example of an organization, a very large health system that's struggling with this. This is how they collect the information. They collect it via a paper form. And so they're getting a very, very low response rate in terms of their granular ethnicity, because when the individual sees the form and sees 80 categories, it's very hard to decide what to check off. Conversely, other organizations that are electronic and can use drop-down and have communication that's taking place between a registration staff person or somebody who is charged with collecting the data can have a conversation with the person that they're collecting it from, and they have the IT system to be able to look at 100 or 200 ethnicities, however that's designed, and I'm not going to go into the details of it because it can be designed. That's a completely different animal. So I think it's very hard to make a standard recommendation to organizations about how to deal with that one field. But there are ways to work around it. There are very detailed ways to work around being able to capture all of those data elements, but recognizing that organizations are at very different points in terms of their capacity. And if we tell organizations that they have to wait until they have the IT structures to be able to incorporate 100 different ethnicities, we'll be waiting for quite some time. It really is time to move forward and to collect the data and to use it. So,
Other thoughts?
One thought is that as a result of the recent legislation, we probably are going to see more efforts at standardization anyway, and this is something that Barry may want to comment on, both not just in what is collected, but how it is collected, and organizations that are receiving federal funds in any form are probably going to, over the next couple of years, find that they are going to be facing some standard approaches that will be coming from the Office of the National Coordinator. So I think a lot of our discussions about standardization may actually, we may say what we would like to see, but I think over time we are going to start seeing some standards coming out as a result of the legislation. That's point one. Point two, to your point, Ramona, I agree completely about the lists. One of the things that we know is one of the reasons that we don't either ask or hand a list of 200 ethnicities is that people tune out when you're asking them or when they see a list after about the third one. And they, particularly if you're asking it in an interview, they want to get the interview over, so they will say something quickly as you go down through your list. And one of the other things that we know is that what people respond is highly contextual. So whether if it is a sort of a quick interview, whether it is with a sympathetic person possibly of the same ethnicity speaking the same language, you are going to have a very different response to that question. It is one of the things that we see as a statistical agency is how flexible people's ideas of ethnicity are in different contexts. And when we talk about standardization, we talk about standardization of what we report. We sometimes talk about standardization of a question. We don't ever talk about standardization of how a question is actually asked and in what context. And that also is really critical.
Okay. Marcia, let me just do one quasi-housekeeping, but then we'll let Marcia. We're about to the point that we should open this up for some comment or questions from the audience. So I think I will ask the staff to at least get ready with the microphones, and those who wish to ask questions or make comments, just indicate to one of the folks with the microphone, and we'll try to get around to everyone. But while that's beginning to happen, Marcia, go ahead. And then Barry.
I came to Washington. I moved down here in 1982. And I remember one of the first meetings I went to, someone said, something about something, and they said, don't make the perfect the enemy of the good. And I thought, wow, I love that expression. And about 10 years ago, I'd vowed I would never use it again. But I got to get it out right now because you can get into this cycle of trying so desperately to capture all information. In a healthcare situation, every bit of information about a person's background, heritage, ethnicity, culture, any identification, you mentioned many, many more than race, ethnicity, and language, is relevant and important in a health context. And it will never be able to be captured in any uniform, usable way across the health system. But it doesn't mean it's not important to be captured in some way in a health record. And so there should be opportunities to capture this information. I mean, I think that if you were in a health system and they said they had one field, you'd have people sitting around for a few hours debating, and you'd come up with an answer. And I would argue it should be something that's a common category, like the OMB categories, or if it was an organization that that made no sense whatsoever. For example, it was in a community where 90% of their patients were Chinese, but had subcategories of Chinese languages and culture, then I would argue that they might want to do something different. But I don't think that it's ever going to be possible to capture in a field. And I don't know that these fields are designed ever to do that, because they're captured also at a place in an organization that's not adept at doing this and getting to the nuances of what a person actually is.
True. Barry, and then we'll go to questions.
Yeah, I think I'm completely in alignment with all the comments made here, particularly about a pragmatic approach right now. We know from our analysis of the Medicare data as it exists now with all the warts in it, that clearly when you're looking at Caucasian categorization, it's 100% or close there to accurate. But interestingly, for African Americans, it's about 97% accurate. And as far as we're concerned, that's way more than is needed to move on to at least start adjusting things using Caucasian and African American. It gets down, if you go to Asian and Pacific Islanders, it's less. If you get down to Latino, Hispanic, it's even less. But we can proceed, as we are right now. We're implementing the first value-based purchasing program at the federal level in the United States for dialysis facilities. It involves a bundled payment reform, and it involves a quality incentive program that merge together. And as you may know, in dialysis patients, there's a heavy preponderance of African Americans. There's 40 to 45% of the entire dialysis population, African Americans. Some units, 100%. So we have to, in some of our opinions, adjust, particularly with that kind of accuracy, for race and ethnicity in that particular program. I think, though, as we go along, we'll want to work on trying to improve the accuracy of the other areas, because it is critical to know that, particularly if we're going to share local data with local communities. And at a federal level, this being able to combine and aggregate data supplementary to whatever we collect from local communities. This is something, again, that Mark and the Brookings folks are doing on the private sector side. We're doing on the public sector for just quality data, where you can aggregate this data. So by taking, and we find that it's different, the results are different in these different settings, but we can, on average, improve the overall quality of the data.
Okay, do we have a question or comment? Yes? And if you could briefly identify yourself, just so the group knows who we have. Please, over here, go ahead.
I'm Tom Kierak. I'm coming from the outside the medical healthcare profession. So I just wanted to see if any of you guys collected data on health literacy or trust of the medical profession, just because sometimes I feel that's half the problem. For example, yesterday I was at my heart doctor, and a mother and son were talking. The son was 7, and the son said to the mother, "Well, the doctor just said I have to cut down on salt." And the mother said, "Well, that's not going to work." So I thought, well, the 7-year-old's smarter than the mother in that position. So.
Okay, any comments on the health literacy issue?
Or I was going to talk about the trust issue.
Either, go ahead. Okay. Go ahead. They're both in play.
I can come back to, but I'm speaking for myself and the organizations that I've worked with, and that includes hospitals and physician practices and others. Nobody's collecting information at the practice or the hospital level about trust, but there is quite a bit of information in the literature about trust in the healthcare system. So what we have done is try to understand, and Dr. Lumpkin referred to a survey that was done by RWJ in early 2000 around perceptions of organizations collecting race and ethnicity data. We did a study at Northwestern Memorial Hospital to ask patients about how they felt about their healthcare organization, their hospital, or their doctor's office, or their clinic collecting race and ethnicity data. And it was interesting because we framed it as should organizations collect this to improve overall quality for everyone? And over 95% said yes, absolutely. But when asked, are you worried that this information could be used to discriminate against individuals, a large percentage also said yes. And of those that said yes, the large proportion of them were racial, ethnic, language minorities. So that clearly speaks to not so much collecting trust information within the healthcare system, but recognizing that how one collects race and ethnicity data directly from patients or from their family members really has to be done in a way that can assuage their concerns about how the information will be used. And that's part of the comment that was made about standardizing not just the categories for how the data are collected, but also the approach that is used to collect the data to address the concerns about trust.
Health literacy. Health literacy is often operationalized within an LEP context. And so people who speak a language other than English are sometimes asked about their ability to speak or read English, trying to get to some of those issues, not just the use of an interpreter, but whether materials in their own language, written materials, would be useful. There are, to my knowledge, few hospitals that actually ask those questions routinely. And I think even when they do, it only gets to a tiny piece of the issue of health literacy, which is just a much, much bigger problem.
Just let me press the point a little bit, because I think that it's a very important question. Are there examples that we know of whether it's hospitals or others, who are regularly collecting information on health literacy among English speakers or among others, and recording that and using that in some way? I think that was the essential spirit of the question, right?
I don't know any. I don't know any who routinely collect that in a manner that's like at registration or that could be used throughout a health system. And I don't even know what they'd ask.
Right, and that, exactly, there'd be a question of how it is operationalized in that context, and can you ask it, do you test it, do you measure, right? But I'm wondering if we knew of examples.
I don't have an example, but there is a fascinating little piece in the health reform bill. It's really worth reading the whole bill, because there are some real treasures buried in there. And there is a very interesting piece in there about health literacy with regard to prescription drugs, and a provision for looking at the effectiveness of quantifying the risk of prescription drugs and putting it on drug labels. It's the sort of like food labeling, drug labeling a model. And there is a provision in there for follow-up studies to look at the effects of this on people's understanding of the risks of prescription drugs and their use, and it looks specifically at racial and ethnic differences in that understanding. So I don't know how they're going to do that. I don't know quite who's going to do it, but it's a very interesting example of people beginning to think about these issues.
Good. Yeah, Barry, and then we'll go over to this side.
Just quickly, David, I think I'm also not aware of any place that is routinely on every admission getting this data, but I am confident that there are quite a few places that are regularly collecting this kind of data. My main home is in San Francisco General Hospital. Kevin Grumbach and the team that are there measure this kind of information quite routinely. Maybe not every admission, and I suspect there are many others that do that too.
Good service model. Okay, do we have a question on this side?
I'm really pleased to hear that the African-American data is 97% correct. However, African-Americans are not a homogeneous group. You have various people, the immigrants from Africa itself, you have various different groups that don't speak the same language or have the same culture. But every health discharge data that we have one category for all blacks, either black or African American, which is very, very disappointing for people who work in organizations that try to help these immigrants, bring them to situations where they can easily access health and social services. I must say I was really disappointed when I filled out the census form recently. It had one category for black. is there anything that can be done to change that?
Well, just as a quick response, I think you have stated a fairly compelling argument for the collection of the granular ethnicity, which would include multiple groups within the larger Black or African origin category. Now, immigrant status is a slightly different issue. So maybe just by highlighting those two things, let me turn and see if we have responses from the panel about that. But I think in general, the call for the more granular ethnicity would be at least a partial response to your question. Others?
I think this census is going to be really a fascinating exercise that we haven't seen before. I would say this is the first YouTube census and Twitter census. And if you go online now, and if you look at Twitter and you look at YouTube, racial and ethnic subpopulations are out there urging their members across the country to address this issue in their census responses. There are some really fascinating YouTube videos out there on the census and saying, and particularly in the Arab American community, the one I have been watching most closely, saying, go to the section other race and write in Arab American. And this movement has spread all across the country, from what I can tell, from some of the videos that are out there. And I think we don't really know what we're going to see in this census as a result of the use of social media to promote people writing in their particular ethnicity. And I think it'll be fascinating to see. We know that the census won't formally release those data, but they will be available for analysis and they will be available for research, is my understanding, what is written into that other category, and it will provide an opportunity to look at some of these questions.
Good. Yeah, Barry?
Yeah, I think this raises some really interesting issues, I think. I was thinking earlier, I jotted it down, that when you're looking at race and ethnicity versus primary language, the primary language is more difficult in some ways because, one, it can change over time. People may change their primary language. And then two, I think the context, are you talking about the home setting? Are you talking about their business setting? Are you talking about their cultural community setting? It could be a different primary language. But now with this, in Africa in particular, if you talk about my lifetime, the countries, if it's country of origin, they've changed dramatically. The globe that I had as a kid is hardly relevant to today. Do you use country? Do you use tribes? What is the context? So I'm afraid that we aren't very far along in that particular area. We focused in, as the IOM report, more on existing ethnicities and subcategorizing those, but we have a lot of work to do, clearly.
All right, I'm sorry, let's try.
Can I make
Okay,
one
real
comment?
quick.
I do have to make one comment. I think that this gets back to kind of how many granular ethnicities do we provide. And it makes sense, clearly, to do it within the context of the local population, what quality measures are being tracked, what languages are being spoken within a community. But whether an organization offers 10 or 20, you always want to have the opportunity to provide a write-in response, because that write-in allows individuals to self-identify if they don't see themselves reflected in the list of categories that are offered. It also enables the organization to track, to see if there's an increase in a specific population that they might not have recognized. So the list does not have to be exclusive in that you cannot capture changing demographics within a community by offering that write-in response, but it has to be tracked. So,
Okay. Question here?
Good afternoon. Thank you, panel. I'm Sonia Boone, and at the American Medical Association, I'm the Director of Physician Health and Healthcare Disparities. And the study that Dr. Hasnain Winia is referring to, I was involved with Northwestern. I was Director of Diversity and Medical Director of Physician Recruitment back in 2004, when we turned on the switch to actually collect information on race and ethnicity. And an interesting thing happened. A year before that, as Northwestern Memorial Hospital was one of those 7 hospitals in a consortium to look at this and start studying the data and how to collect it. We did a study, I was consulted to the study, and looked at what is the preamble that has to happen, the question that the admitting person has to ask in order to get a response and not put up a brick wall with patients. And there were 3 different ones that leveled down to 1 preamble, and that actually included this, it's not a government, that was rejected right away. Government, this data was going to be used for government purposes, et cetera. But the one that leveled the most effective in the study the year before was this is to improve the community, health of the community and quality to all patients. So an interesting thing happened. That was almost an internal experiment. When they turned on the capacity to do this, the preamble was left off of the field. Now, the luxury of having an electronic, response system so that the preamble could be right in how the person asked the question, the preamble was left off because someone in IT did not, there were too many lines, it was felt. And so it was left off, and we didn't know that. And we started collecting the data, and we found that, wow, the data wasn't being collected to, somewhere around 10%, 20% of the time. It just didn't make sense. Another thing that happened was the staff was supposed to go through training, and admitting didn't actually take them through training. Dave Baker, has done so much work on physician-patient interactions and health literacy. We were involved in this together. And so 2 things happened. The preamble was left off, and the staff were not trained. So we had to go in there, and train the staff. And we found 2 major things that had to happen. And this puts the face on what Dr. Billheimer was talking about, also what Dr. Husnam-Wenia was talking about. And that is connecting this and how the question is asked is very important, actually, and gets buy-in from the person asking the question, and it gets buy-in from the person answering the question. And so once we had the training and we connected it to the mission of the hospital for the trainees, for the admitting staff, because often they would say, well, I don't know why the hospital is collecting this information. That did not engender trust in the patient being asked the question. But once they went through the training, they said, oh, wow, this is going to help our doctors, create better quality of care, know who they're treating, et cetera. So we got the buy-in through the training. So connecting it to the mission of the hospital, and also to, oftentimes they're patients at the hospital, so they want to know, wow, this is going to improve quality. And then the other thing is making sure that they know that this is not, both the trainees and the patients know that they're not guinea pigs. This is not an experiment. This is a commitment on the part of the hospital, the FQHC, the doctor's office, to really go forward and continue this effort that's going to be sustainable. So I wanted to insert that because it's very important, and it's part of cultural competency. It's about communication, and communication with the staff, cultural competency with your staff, cultural competency with the patients as well. So thank you.
Okay, I think that's an excellent comment. We may have time just for one more question. Ruth here.
Excellent panel. I'm Ruth Perot with Summit Health Institute for Research and Education. And we've worked with the National Health Law Program and a number of advocates in this room with CMS since 2001 to help you enhance the data collection by race, ethnicity, in primary language, and have run into the same barriers as you reported just a minute ago. So we're looking forward to seeing this report coming out in April, but we have some concerns. We've never quite understood if the data you get from SSA is not adequate. SSA has recently improved its form by which it collects data on race and ethnicity from persons applying for new cards, but most of that data still comes through the enumeration at birth process. That data is spotty, inadequate, certainly doesn't meet OMB categories, and you often don't even get it. Why don't you collect your own data? Why doesn't the CMS collect its own data? You pay CMS, SSA, for a substantial amounts for the data that's not really meeting the purposes. And so the tough question that we've never understood is, why don't you move toward collecting your own?
I think that's a rather complicated answer, not to dodge it, but the way that the regulation of the Social Security law has been set up, first of all, prescribes part of why the process the way it is. So it would require a statutory change for us to change some of what we want to do. People often think that CMS can just do whatever it wants. We can't. We're bound by laws and regulations that are extant. I think the other thing is that the authority for CMS, if we were to collect it ourselves, would be limited to the Medicare population alone. Whereas if you have Census Bureau, Social Security Administration, et cetera, one of the advantages to me would be that you can get national data for all age ranges and for all locations and not restrict it to the Medicare program alone. So those are too simplistic. It's much broader than that, I think. And there's, as you well know, there's many, many other issues that make collecting this data by CMS quite problematic. But I think we're going to, again, if Congress will, and we've had discussions with them, be interested in some of the proposals that we've made, in my mind, that'll go a huge forward step in improving our data.
All right, we have come just about to the end of our session time. There are a couple of things I've been asked to mention. One is that there will be a break, and then following are the morning breakout sessions. This room will be reconfigured, so you can't leave anything here. Otherwise, Lord knows what will happen to it. I hope we've been able to set the stage for some of the discussion that follows. I'll just mention one thing specifically. Our discussion has been almost exclusively about ways of collecting data directly from individuals, but we know that particularly in the health plan context, in spite of the most strenuous efforts by wonderful national examples, that's been a challenge. So there is a session about some indirect methods that at least I want to make sure you're aware of, because we, I'm sure for at least a while, are going to have to be thinking about that as well. Kaylan, are there other announcements?
Want to take the time to ask everyone. My name is Kaylan Taylor-Clark, and I'm part of the high-value healthcare team at the Engelberg Center. We want to thank you all for being here, but we also want to thank the panelists today. And if you could join me in giving them a hand. As David mentioned, we are taking a 15-minute break, and then we'll ask everybody to go to your breakout sessions. So we'll reconvene here at noon for Dr. Benjamin's talk. Thanks again.